So this particular presentation is on the treatment of co-occurring conditions in outpatient MAT programs. And this is real life. This is something that we will see more often than not in the treatment of opioid use disorder. So it's important to know how to manage these patients. Okay, trying to advance. Boy, having the hardest. Okay, here we go. Slide. Okay. All right. So, so here's the outline. We're going to talk a little bit about the prevalence of both substance use disorders and mental health disorders. Actually, first, we're going to do a case vignette. So that's a little out of order. So we're going to do a case vignette. We'll do epidemiology of both substance use disorders and mental health disorders. We'll talk a little bit about the epidemiology of co-occurring conditions, how they tend to cluster with respect to different mental health conditions and substance use disorders. We'll talk a little bit about what appears first in generally in adolescence, and talk a little bit about the causes of each respective illness, and then we'll talk a little bit about the treatment of co-occurring conditions, some of the evidence-based practices, and hint, hint, it involves a multidisciplinary approach. All right, so first I'm going to start with that case vignette. This is a patient that I treated about a year and a half ago. She had been treated at a tribal health program in the past, but I had actually seen her in my private practice. She's a 27-year-old female with schizoaffective disorder, severe opioid and stimulant use disorder. She began using oral opioids in high school, and that was followed by smoked methamphetamine, and then eventually she moved on to IV use of both methamphetamine and heroin. She began hearing voices and becoming paranoid at the age of about 20, and this was intermittent. I could never get a great sense of whether it was, well, how much of her psychotic symptoms were linked to her drug use. It definitely seemed like it had been worse when she was using, although there were periods of time when she had psychotic symptoms apart from using drugs. So she really did have two independent conditions, though they were linked in some way. Unfortunately, this young woman was diagnosed with sarcoma, which is a form of soft tissue cancer. This was in late 2015. She began chemotherapy for that. And after just a couple of months, she had a relapse of her substance abuse issue, and that as I mentioned, lasted 1 to 2 months. She re-entered residential treatment and became sober again, abstinent. She resumed her chemotherapy, and then she did well from a cancer standpoint, with her tumor really shrinking to almost nothing for about 8 months. So she was really stable for 8 months. Unfortunately, she relapsed again with respect to her substance use disorder and went back into residential treatment. But while in residential treatment, she began to become very psychotic, and she the folks at the residential treatment program didn't know what to do about it. They didn't know whether she was, how much, whether she was faking some of it. She, um, uh, kind of long story short, she didn't get treated for a psychotic disorder. And she eventually, after being kind of disruptive in the milieu, left treatment, and she disappeared onto the streets for about 5 months. Family didn't know where she was until she was finally arrested. She ended up breaking into someone's home confused. She wasn't trying to steal anything. She was just confused, and was um, an elderly woman who lived there, and could knew that there was something wrong with her, and ended up calling the police and kind of comforted her in the meantime. Without her cancer treatment, she, for about 7 months, unfortunately, the tumor metastasized, and I'm sure all of you had jumped ahead to the bottom part. I began seeing her as an outpatient. She did stabilize with respect to her mental health and substance abuse treatment. I started her on Suboxone and got her started on antipsychotic. Some of the folks that knew her said that she was doing much better than she had been in quite a while. Unfortunately, she relapsed for a few weeks. She kind of disappeared over the Christmas vacation, and came back in, but she eventually died in a little over a year ago. And kind of a big part of that was that she she didn't get her psychiatric condition treated um, during the period that she was in residential treatment, and that led to her being inappropriate for that particular setting, and she ended up leaving, and of course the result was tragic. So, certainly this is an unusual case, but you kind of take out the cancer part, and a lot of times people will end up yeah, relapsing, just because their psychiatric condition isn't um, adequately treated, and in other cases they relapse, leave the program, and they end up overdosing instead. So um, bad things happen when folks aren't treated adequately. So a little bit about the prevalence of addicted disorders. This is the National Survey of Drug Use and Health by SAMHSA, and there's about 22 million um, folks with addictive disorders in the US, and these are moderate to severe. So these are clinically impairing conditions. And as you can see, about 2/3 of those, a little over 2/3 of those, are alcohol only. There's about a fifth of those folks that are drug only, and then there's some substantial portion that use both alcohol and drugs. And again, this is a survey of just the general population. So this is not your clinical sample that you might be familiar with in your work. This is just kind of calling John and Mary Q public, and looking at their conditions. So prevalence in substance use disorders, just kind of another look at this in terms of percentages. So the 12-month prevalence for substance use disorders are um, about 6% of the population for alcohol use disorders, 2% for drug use disorders, and those who have both are about 1% of the general population. So general population of 3.325 or 325 million. We're talking, like a little over well, I'll let you do the numbers. But about a total of 9% are folks with serious addictive disorders, and that's usually in the literature you find anywhere from 8 to 10% generally cited for a large population, and certainly is the case in the United States. So kind of looking at it from the mental health end, and this is a 12-month prevalence. So at any given 12-month period, about a quarter to, as you can see, 28% of the general population has an active mental health condition. Now, this is um, one that has some seriousness that's affecting their life in some way. It doesn't include factored out trivial phobias, snake phobias and that kind of thing. But here for the major conditions, here are the figures. ADHD, about 4% of the population, and this is the general population. So in kids, the percentage is more. It's about 10% in all kids. If you look at the whole population, including adults of all ages, it's about 4%. Anxiety disorders, and again, these are kind of more serious ones: generalized anxiety, um, social phobia, panic disorder. Those add up to be about 10%. Bipolar spectrum illness is about 2 to 3%. Depression is about 7%, and PTSD is about 3.5%. And these are, usually when they report out prevalence data in populations, a lot of times they'll report it by citing the 12-month data and then the lifetime prevalence. So you guys might maybe have heard some other figures um, for for lifetime prevalence, and of course those are going to be much greater. With depression, it's more like 20%. But people, have long periods of doing well that have depressive disorder. So this is just kind of a snapshot, and this is really what we're looking for when we're looking at co-occurring conditions, because we're looking at conditions that are occurring at the same time, and so kind of true to the description of co-occurring. So the epidemiology of co-occurring disorders. So the first thing to say is that the data is pretty messy. Um, a lot of there have been a lot of studies that look at the co-occurrence of these two categories of conditions, but they generally look at slightly different populations, and sometimes it'll be disease condition specific, and a lot of the data is contradictory. So it's it's pretty messy out there. But there are a few things that come through all of the background noise that's in the data because of the differences in the studies that I'm going to cite for you. So just based on the previous couple of slides, first of all, mental health disorders are about 3 times more common than serious substance use disorders in the general population. Of course, that's going to be different where you are treated. And in general, for PTSD and bipolar disorder, um, co-occurring disorders are the rule rather than the exception. So, there are a couple of conditions that have high co-occurring prevalence with substance use disorders, and it is true that it's more common than not for it to be co-occurring with substance use disorder. So that's certainly true for bipolar and PTSD. Not all of mental health conditions are more commonly um, co-occurring with substance use in a general population, but those two they are. So the presence of a mental health disorder with a drug use disorder from a percentage standpoint is greater than those people with an alcohol use disorder and a mental health disorder. And that sort of um, follows from the general principle of the more severe either condition, either the substance use condition or the mental health condition, the more likely that there's going to be co-occurrence with the other set of disorders. Um, again, a lot of times it depends on what kind of setting you're in. In a residential treatment setting, the rate of co-occurrence of mental health disorders is over 80%, and some studies it's more like 90 or greater percent. So it really depends on the population you look at. Of course, in an outpatient population, it's going to be a little less, but still very significant. So kind of looking at specific mental health conditions. And this is the prevalence of a substance abuse disorder by mental health conditions, and it's listed there. ADHD. It's about 3 times more likely. Folks with ADHD are 3 times more likely to have a substance use disorder than the general population. Anxiety, it's a little higher. Depressive disorder, there's some variation in the data, but most of the data averages about 4 times more common in folks with depressive disorders. PTSD, as I mentioned, PTSD and bipolar, they have a higher rate of having co-occurring substance use conditions, and it's more the rule than the exception, and a lot of times 7 to 8. And I think that these are really underestimates. A lot of these are based on meta-analyses. So kind of looking at multiple studies and trying to get data. And a lot of those studies are older. So as in time, as time has gone on, the co-occurring prevalence seems to be greater and greater, and I think that's just because we're better at detecting it, as well as there's I think a real increase as well. So just kind of another look at this, and this is looking at adverse childhood experiences for I would imagine a lot of you have heard of the ACE study. For those who haven't, the Adverse Childhood Experiences study basically looks at 10 different types of adverse experiences in childhood, and these include different types of abuse, neglect, other unfortunate things that occur in childhood. There's 10 of them that are in the formal data set, and then they've looked at disease conditions later on in life, in adulthood, and have found very significant, startling correlations. And I just wanted to bring your attention to that, the right-hand side. So folks with 4 or more adverse childhood experiences are about 11 times more likely to have an alcohol use disorder or an IV drug use disorder. So it's much more common. I don't have the slide on here, but there's data to suggest that suicide attempts and/or completions are about 30 times more common in people with 4 or more childhood experiences. Now, adverse childhood experiences don't always mean automatically mean a mental health condition, but it increases the risk. And so this can be sort of um, a proxy for mental health conditions. All right. So one of the questions that researchers have regarding co-occurring conditions is number one, what comes first? And number two, what causes what? Why do we have conditions that occur together? And to answer that first question, in anxiety disorders and ADHD, the onset of the mental health disorders predates the onset of substance use disorder by about 10 years in studies. And this provides support for the self-medication hypothesis of substance use disorders. And I see a lot of this. Um, I admit kids at Desert Sage Treatment Center in Hemet, is the IHS's adolescent treatment center for substance abusing youth in Southern California, and many of them basically state um, anxiety or just kind of overall distress as one of the main reasons that they started using to try and make themselves forget or to deal with some very unpleasant feelings. So there's, in terms of causality, kind of besides self-medication, there's different possibilities. You can have the possibilities are the mental health condition predisposes a person to substance use disorders. Could be the other way around. The substance use disorder predisposes to the mental health condition. It could be that there is a common genetic vulnerability that occurs with both conditions, and or there's kind of the bidirectionality explanation, and then that kind of is a seesaw. That's you get some symptoms, and that causes a higher likelihood of having symptoms in the other category, and so they just kind of ratchet up together. And in terms of sequencing of depressive disorders, it appears that that explains the co-occurrence of depressive and substance use disorder. There seems to be this bidirectional phenomenon with some depression causing substance use disorder, but then you also have the case where someone will have a substance use disorder first, and it'll cause their depressive disorder later. So there's kind of goes back and forth. And then the fifth possibility is that they're totally independent, and that is not supported by the data. There's definitely a link. Okay, so I'm going to move on to conditions which tend to cluster together a bit. There are the tendency for certain mental health conditions to cluster together with certain substance use disorders, or to kind of say it a different way, use a different kind of an attraction for certain substances. And this indeed seems to be the case with folks who use prescription medications illicitly, particularly benzodiazepines and opioids, um, for um, for folks with anxiety disorders. So folks with anxiety disorders are, they particularly cluster with the central nervous system depressants. And kind of this is one of those conditions where the self-medication hypothesis, I think, is very valid. You see a lot of alcohol and cannabis use co-occurring with anxiety disorders as well, and there's some of that has to do with self-medication. Additionally, there's central nervous system depressants. So when someone is in kind of an agitated um, state, then they look for something that to calm them down, and alcohol and cannabis do that to some extent. So that's pretty common, as well as alcohol and cannabis are everywhere. So co-occurring clusters, ADHD, children with ADHD, this is correlated with higher rates of alcohol, cannabis, and stimulant use disorder. Again, alcohol and cannabis, some of that may have to do with availability, but stimulant use disorder is interesting. There's a correlation between an ADHD diagnosis and later development of cocaine use disorder, and this follows the follows the self-medication hypothesis as well. There's always been some question about whether the use of medications for ADHD actually cause a substance use disorder, and increasingly it's looking like that's not the case. As a matter of fact, pretty convincingly by now, we've got enough data to say that that's not the case, that it actually decreases the risk, and we'll get to that in the treatment section. So some general principles about treating co-occurring conditions. Um, so one of the things that's important to remember is that in substance use disorder treatment um, um, programs of any kind, if there's untreated mental health conditions, then this will decrease the likelihood of a successful recovery by 50%. So if someone has, any type of substance use disorder, and they've also got a mental health condition, then it's going to be harder for them to be in recovery successfully, and particularly if that's not treated. So it's very important to treat the underlying mental health condition as well. In general, following that statement, in general, co-occurring conditions are more resistant to treatment and generally have more worse outcomes as a group than folks without a mental health condition, or either a substance use disorder without a mental health condition, or the other way too, a mental health condition without a substance use disorder. Just the disorder alone. So the good news, if there's a little silver lining with this, is that in cases with mild to moderate impairment or a mild to moderate co-occurring condition with the primary condition, sometimes the treatment for one of the condition will lead to a satisfactory improvement in the other condition. And I see that a lot of times with residential treatment. You might have someone who goes in for a primary substance use disorder, and they may have kind of a mild to moderate depressive disorder or anxiety disorder, and some of the counseling that they get in the residential treatment facility will really be enough to kind of get them over the hump in terms of that co-occurring mental health condition, and they get better. So that's always nice. Tends to be a little more difficult if it's a more kind of moderate to severe mental health condition. That's a little harder. It's kind of another treatment principle in co-occurring conditions is do no harm, and we'll talk a little bit more about that in the following slides. Integrated mental health and substance use treatment has shown to be superior than treatment that's separated. So if there can be some coordination between the mental health and the substance use disorder treatment, that is better than just having it separate, and which is pretty much the case in general with other fields of medicine. If there can be communication between providers, and folks usually do better. And another principle is that it's important to use principles of chronic care management, and that's case management is a big part of that. Tracking folks, making sure that they don't fall through the cracks. Okay, so treatment of some specific co-occurring conditions. So substance use disorder and in the presence of ADHD. So again, this is something you'll see fairly frequently, and the data that I showed earlier, the 20 to 25%, that's for general population. It's going to be higher, in your treatment settings because you have more severe disorders. 25% of all substance abusing adolescents meet diagnostic criteria for ADHD. So that's one of those cases where you'll see that co-occurring condition start early on. Um, of course, we don't know the reason for co-occurrence for sure. When things are related, you don't always know that one caused the other, but the data, the fact that ADHD generally occurs, a lot earlier than the substance use disorder does suggest, at least to some extent, the self-medication hypothesis. Um, Untreated ADHD leads to significant consequences and may impair a person's ability to benefit from substance use disorder treatment. And in particular, folks with ADHD have trouble with impulse control, which is really a very important aspect to develop in substance use disorder treatment. A little bit more on co-occurring SUD and ADHD. Stimulant medication, it does have abuse potential, but when it's carefully monitored, and I put cures in there, it's important if you're treating someone with any type of controlled substance to look at their cures report. Evidence shows that it can be safe and effective in folks with a substance use disorder treating their ADHD. And in fact, the more recent research suggests a lower incident of substance use disorder later in life among kids that are actually treated for their ADHD, as opposed to kids with ADHD that are not treated. And there was also a study about 2 or 3 years ago which demonstrated improvement in both ADHD as well as the stimulant use disorder. Now this was in adults that were treated with extended release amphetamine salts, so Adderall. So if it's monitored very closely, um, you can treat someone with a stimulant and with that has ADHD and a substance use disorder with a stimulant, and if you monitor it carefully, they'll get better. Some of that has to do with the fact that the rate of oral absorption with the ADHD medications is much slower than either smoking or using the substance IV. So it's really not the same experience for the stimulant use person with stimulant use disorder. It's really quite different, and there's a little bit more of a concern about diversion with stimulants. That's an important concern because can be crushed and altered and either smoked or injected. That's a different matter. And if you know, you always have to be on guard for diversion of medications. So treatment of substance use disorder with a co-occurring mood disorder. Kind of as indicated before, among individuals with a mood disorder, about a third of them have a co-occurring substance use disorder. And again, this is in general population, so in clinical samples, it's going to be higher. Um, and this is, as I mentioned, one of those conditions where the substance use disorder can actually cause the depression. So it's important to kind of tease things out. However, despite the possibility that substances can sometimes be involved in the development of a depressive disorder, um, it, there's a little bit there's some data to suggest that it's if you're going to start treatment for it, it's better to do it earlier rather than later. It used to be years ago that if someone came in to a treatment program for their substance use disorder and they were also depressed, you'd want to kind of have their brain dry out. And there's still something to that principle, but it as it turns out, um, they just seem to do a little bit better if you address the depression earlier on, because even if their depressive disorder may be substance induced, that doesn't mean it's going to go away when you stop the substance, and may just persist. So it's right now we're kind of the earlier the better. If someone's got a significant diagnosed major depression, then it's really better to get that treated earlier on, and they can participate a little bit better in their treatment, because depression affects your memory and concentration and motivation, importantly. Folks with co-occurring substance use disorders and mood disorders, these are people that you need to see a little bit more frequently, because they're at a little higher risk of relapse. So sometimes it can be helpful to have a case manager work with these folks and contact them if they end up not making their appointment, and kind of spend a little bit more time, just sort of um, tracking them and helping them out. And also, talk therapy and counseling is a bigger, more essential part of treatment with co-occurring conditions. There's as a psychiatrist, I treat a lot of folks with depressive disorder, and some people do fine with medication and just kind of a little bit of supportive psychotherapy that I provide, and they get better. But you don't want to take that approach with a person that has a co-occurring substance use disorder. You want to make sure that that person is getting therapy or substance abuse counseling as well, unless they've been stabilized for a long time with both. Um, Treatment of co-occurring SUD and anxiety. As I mentioned before, you know, with anxiety disorders tend to gravitate towards the CNS depressants, and benzodiazepines are a favorite. And I, frequently have folks that I'll accept into treatment for an anxiety disorder, and they will have been on and also substance use disorder. Um, they will have been on a benzodiazepine in the past, and they, will ask for them, kind of thinking that, this was the only thing that seemed to work for me in the past, and are sometimes upset when I don't want to put them back on a benzodiazepine. Um, and this is part of that do no harm. Benzodiazepines are relatively contraindicated in treating anxiety co-occurring with a substance use disorder. especially with alcohol use disorder and or benzodiazepine use disorder. There's some exceptions to that. Um, um, I generally will try all kinds of other medications for anxiety disorders. The selective serotonin reuptake inhibitors. So our main depressive disorder treatments. Those are first line agents for most of our anxiety disorders. Also the Cymbalta and Effexor, SNRIs. Seroquel, quetiapine has been shown to be effective for most anxiety disorders. Roxazine, beta blockers, gabapentin, pregabalin, DCAs. There's lots of other things that can be tried, and a lot of times I will do that. One of the key principles of treating someone with uh, substance use disorder and co-occurring anxiety disorder, well, with any anxiety disorder for that matter, it's very important to start very, very low with with an antidepressant, because these folks tend to be very sensitive to um, any type of agitation feeling, and sometimes in the very beginning of antidepressant treatment, a few days of kind of jitteriness. And a lot of times, especially in folks with co-occurring substance use disorder, um, they have this expectation of very rapid relief from their anxiety, and you really need to spend some time working on that idea that that's not really a reasonable expectation, and anything that is going to give you very rapid relief is likely going to become a problem for you if you have a substance use disorder. Um, so um, so it takes a little bit of patience and finesse with these folks, and generally talk therapy is usually indicated. Um, so again, it's not that I never treat folks with benzodiazepines that have a substance use disorder, but it's a kind of a last ditch type of thing, and sort of for it's a don't try this at home type of thing, because I will try all kinds of stuff first. I as a addiction psychiatrist, I kind of have the time for that. So we talked about some of the treatments for co-occurring conditions, and just kind of wrap it up by saying that it really requires a multidisciplinary approach. Both mental health conditions and substance use disorder conditions can be well characterized as being chronic neurobehavioral conditions with disruptions in biological, psychological, social, and spiritual domains of life. So you really need to pay attention to the whole person when you're treating folks with either of these conditions, particularly when folks have co-occurring conditions. And again, a lot of times case management is important to, um, for these folks. A lot of times they end up falling through the cracks. It's kind of, you can think of it like for primary, anyone in primary care. If you have there's certain diabetic patients that are extra brittle or vulnerable, and you want to kind of keep closer watch on them. Sometimes it's good to have a list of folks with co-occurring conditions, just so you can follow them very, very closely. Tribal and urban Indian health programs are, I think, they're very well positioned to offer holistic care. That's one of the things that I think are a real strength for our system, is that you have medical and behavioral health under one roof, and you can do such a you could do a lot better work if folks are communicating, if you have interdisciplinary team meetings, and particularly with those folks with co-occurring disorders. It's really, really helpful if folks can communicate and kind of track these folks into into their into their time of wellness.